Students, faculty, staff, thank you for attending today. Dr. O'Brien, welcome to the University of Mississippi. We're glad to have you here. I'm proud to add your name to a distinguished list of earlier Hartman Lecture speakers. I now recognize Steve Strum, who will discuss the Charles Hartman Lecture and Legacy.
Thank you, Dr. Forget. Hello, everyone. On behalf of the Ole Miss School of Pharmacy, I'd like to thank you for attending the annual Charles W. Hartman Memorial Lecture. The School of Pharmacy started this lecture series in 1973 to honor our school's third dean, Charles W. Hartman. Dean Hartman's tenure was tragically cut short by an automobile accident nearly 50 years ago. Today, we remember Dean Hartman for his many accomplishments on behalf of our School of Pharmacy, pharmacy education, and the field of pharmaceutical research. I'll show you, in my first month as being the dean, I read this, and I was reminded by Dr. Smith, my professor, that we all stand on his shoulders. He has left a legacy, the beautiful facilities that we have, the strong research foundation, and the strong educational program that we all have been able to take advantage of. Charles Hartman was born in Alabama in 1924 and served as a pharmacist mate in the U.S. Navy and Marine Corps. After his service, he received his pharmacy and master's degrees from the University of Georgia. He then earned his PhD from the University of Florida in 1956 and joined the University of Georgia's pharmacy faculty. Just 5 years later, he became dean of the University of Mississippi School of Pharmacy and immediately set about advancing it even further. He secured funds to construct Phaser Hall, which today serves as one of our main buildings on campus. He also created our Research Institute of Pharmaceutical Sciences, now a world-renowned institute that comprises 5 innovative research centers. Dean Hartman's research interests range from drug absorption to pharmacy administration, and he was granted 8 patents throughout his life related to his numerous investigations. He also served as vice president of the Mississippi Association for Mental Health and was a consultant to the U.S. Public Health Service. He was active in the American Pharmacists Association, as well as many other professional groups. Tragically, this champion of pharmacy education, pharmaceutical research, and the pharmacy profession was installed as vice president of the American Association of Colleges of Pharmacy only 5 days before his death. Charles Hartman had a profound impact on the School of Pharmacy. We are proud to honor his legacy today and to celebrate his many contributions to our school, our profession, and our state. Please join me in acknowledging him. Thank you. It is now my great pleasure to invite our school's Associate Dean of Clinical Affairs, Leanne Ross, to the podium as she will introduce this year's Hartman Lecture speaker.
Thank you. It is my pleasure today to introduce our 2022 Hartman Lecturer, Dr. John O'Brien. Dr. O'Brien is currently the President and Chief Executive Officer of the National Pharmaceutical Council. NPC is a nonprofit health policy research organization that's focused on advancing science and medical innovation, specifically around pressing health policy issues, such as health spending, alternate payment methods, and also biopharma innovations. Dr. O'Brien earned his Doctor of Pharmacy degree at Nova Southeastern University, a master's degree in public health at the Johns Hopkins Bloomberg School of Public Health, and studied pharmacy and public policy at the University of Florida. Dr. O'Brien's postgraduate experience includes the American Society of Health System Pharmacists Executive Fellowship in Association Management and Leadership, and the America's Health Insurance Plans Certified Health Insurance Executive Fellowship. Dr. O'Brien has a breadth of experience in different areas. He has held academic appointments, including Senior Fellow at the USC Schaefer Center for Health Policy and Economics, Clinical Assistant Professor at the Rutgers Pharmaceutical Industry Fellowship Program, and Assistant Professor of Clinical and Administrative Sciences at the Notre Dame of Maryland University College of Pharmacy. Before joining NPC, he served as Senior Advisor to U.S. Secretary of Health and Human Services, Alex Azar, where he led policy development on administration priorities, including improving the affordability and access of prescription drugs. He also served as Deputy Assistant Secretary for Health Policy for Planning and Evaluation and a key advisor to the Secretary for Health Policy Research, Development, and Analysis, specifically related to Medicare, Medicaid, and private health insurance. Dr. O'Brien has held senior policy positions in life sciences and managed care industries, including at Care First Blue Cross Blue Shield, and he was a career official at CMS and served as a health policy fellow in the United States Senate. What an impressive career, and how honored we are today to have him here with us to share from these collective experiences. In each role in the private, academic, and government sectors, Dr. O'Brien, as a pharmacist, has brought a unique perspective of the impact of medications on patient outcomes. I had the fortunate opportunity to meet John when I was a health policy fellow in Washington, D.C., working in the office of U.S. Senator Thad Cochran, who delivered the School of Pharmacy Hartman Lecture exactly 20 years ago. With a shared interest in health policy, I have followed Dr. O'Brien's work through the years. He is an outstanding leader. He has a passion for public health coupled with an understanding of the importance of innovation and drug development. And we have seen how essential both of these are in the recent challenges of the global pandemic. Dr. O'Brien has had a tremendous impact on health policy to this point in his career, and I'm confident that his leadership will continue to pave the way for our future. In addition to his work in health policy, John is quite accomplished in his personal aspirations as well. He is an avid golfer for you golfers out there and an up-and-coming pilot. Thank you, John. We are grateful that you are with us today, and we look forward to your presentation titled Navigating the Healthcare Ecosystem to Improve Patient Outcomes. Please join me in welcoming Dr. John O'Brien.
Wow. I don't know what's going on with the pollen in Mississippi, but I hope the snow makes it clear up. I am incredibly honored to be here for a number of reasons, and it just really hit me. You know, when you look at the people who've given this lecture, it's just an incredible honor to be on this stage. I'm so grateful to you, Leanne, for your introduction, and you know, to the dean and the associate provost for having me here today, and to everybody who might be watching on Zoom celebrating spring break early. I really have to thank the School of Pharmacy for holding strong. When I watched Blake Thompson's Hartman lecture, I heard him say the Friday before spring break, and I said, my gosh, that's got to be a heck of a time to give a speech. But I'm really grateful to everybody who's here and who's online. There are three particular reasons why I'm excited to be here today. In addition to everything that Dean Strum said about Charlie Hartman, I have also read Mickey Smith's book and took away the fact that he was a savvy individual, someone who saw problems as opportunities, and that he was a driven man that some would call impatient and wasn't one to wait around for things to happen. I can relate to that, not just because of him, but because of other Ole Miss faculty leaders who've inspired me, some of whom are here today. I am incredibly grateful that there are a number of people here who don't need an introduction. And of course, Mickey Smith sitting in the front row, the author of over 400 papers and author of an editor of over 20 books, including literally the textbook on pharmaceutical marketing and management. He also took the time to write me a letter congratulating me on becoming the president of the National Pharmaceutical Council. And when I read that I was very pleased to see a pharmacist in such a leadership position, it hit me just as much then as it did today. So thank you, Mickey, for being here. You know, early in my career, when I was interested in government and politics and not sure if it was a real career path, everybody in Washington told me I needed to meet two people. Leanne Ross and Blake Thompson were literally working in Congress before I knew the difference between an appropriation and an apportionment. And that's an inside joke because they're very different and very important. But they opened my eyes to the fact that you could take the important things that you learn in pharmacy school and put that knowledge to use helping patients by doing something else. And it's a lesson that I'll always be grateful for. And it's a real honor to have you here today. To be here is because of you. Over the last 2 days, you have helped me appreciate even more that the job of a pharmacist is one of the most important roles in healthcare. You literally have perhaps the most patient-centered role in healthcare today. You see firsthand the financial burden that the current system puts on patients. You stand at the intersection of science and healthcare and policy, and you're oftentimes the first person people come to with questions about their healthcare. If you are one, will be one, or are responsible for preparing one, then you are the real important people in this room. And it's an incredible honor to be here today, because now more than ever, pharmacists are a critical part of the healthcare system, and you've played an incredibly important part in our nation's pandemic response. But today I lead a health policy research organization, the National Pharmaceutical Council, and we educate decision makers and the public on the value of biopharmaceutical innovation and what that does to help patients. Now, like many of you, I thought that I was actually going to practice pharmacy when I was in school. And a number of amazing experiences happened that helped me appreciate how I could actually help patients, populations at a time instead of one patient at a time. And that's what I get to do today. We do research at NPC on how policy decisions will impact patients and patient access. We don't lobby, we're not a lobbying organization, but we will talk to anyone to understand their perspective and engage in meaningful and evidence-based conversation. It is an incredibly important time to educate healthcare decision makers about how the healthcare system works, or in some cases doesn't work, together so that we can protect access to the incredible innovations from the scientists and the researchers working at America's drug companies that improve patient health. Now, you may be wondering, how did a pharmacy student in Gainesville and ultimately South Florida end up in the nation's capital? And I'm excited to get to share a little bit of that story with you today. But I also want to leave you with 3 key takeaways. First, the importance of understanding the important complications and nuances in our healthcare system. And second, how the perverse incentives and an opaque drug pricing system creates difficulty for patients and those who, like you, want to work with them and help them get healthy. And third, the importance of working together and understanding each other and never pointing fingers. Now, a lot of what I'm going to talk about today, doesn't matter. Oh, you didn't get to see you. Go back one. No, that's a really important slide. That's them. That's you. I wanted you to see yourself up here. Moving on, a lot of what I'm going to talk about today isn't stuff that you're going to hear about in a classroom, but hopefully my story will encourage you to broaden your horizons and stay curious, which I believe will serve you well in the future. Now, if you were with me today in any of the sessions that we've done, you heard me say that when I grew up, I wanted to be a sports broadcaster. I was going to be the next Wade Hubble. And instead, I became fascinated by the role of prescription medicines. And that happened when my mom got. And I couldn't figure out what was different about the white pill versus the green pill. And I found myself not just reading about the science in encyclopedias, but appreciating the value of the pharmacist that would actually talk to her, sometimes even come to the house to deliver medicines and explains how they were supposed to work. And when you're dealing with mental health issues, the difference between a medicine that works and a medicine that doesn't work can be particularly profound. And I wanted to take a quick moment to talk about how these different stakeholders work together. Because while being a pharmacist is essential to who I am and is always who I'm going to be, I began to appreciate how many different parts of the system didn't work together. So let's take a moment to talk about that system quickly. So drug companies make drugs and they ship them to pharmacies. And individual people buy health insurance from payers, and then the insurer pays the pharmacy for the medicine, the drug company gets that money, and the consumer goes home healthy and happy with their dispensed drugs. Are there any questions? Any? That is not at all how our healthcare system works. This is how our healthcare system works. This system doesn't work well to serve patients. And this brings me to the first of the 3 points that I want to drill down on, the 3 areas of knowledge that I think will be helpful to help you become a better steward of our healthcare system. If you dig in, you see that not every part of this system works together smoothly. A pharmacist may want to prescribe a particular medication only to find out that the medicine isn't covered by the patient's insurance. The pharmacist or doctor may be required by insurance to try drugs that are less than ideal for the patient and make them fail first before they can have the medicine that does work for them. And sometimes even low-cost generics are sometimes not available to patients. So when I go back to the time that I spent in pharmacy school, I believed that this was how it worked. And I was working for a community pharmacist in Palm Bay, Florida. And working for Charlie, I began to see how the differences in state regulations and insurance company regulations actually required him to practice differently. And as a result of those experiences, I found myself going to county pharmacy associations and then state legislative days. And like many in this room, I got involved in APHA-ASP. And I became a regional delegate and made my first trip to Washington and said, wow, that's a really neat place. And sometime in my second year of pharmacy school, I was on my way to the golf course and I got a note from the dean's office. And it said that Dr. Schiebler wanted to speak to you. And I said, that's great. Who's Dr. Schiebler? And they said, well, Dr. Schiebler is the executive vice president for external affairs at the university health system. And I said, that's great. I'll go see him tomorrow. And they said, no, you're going to go see him now. So I go down the hall and the door opens and there's this old distinguished man who looks up from his desk and says, I wrote the law that requires children in this state to wear helmets when they ride their bicycle. I'll save more lives this year than all those guys in the emergency room in their entire career. I understand that you're interested in health policy. And you're going to Washington this summer to be the American Medical Students Association's health policy fellow. Now, I didn't know at the time that what I was doing, but I said, Dr. Schiebler, there must be some mistake. I am not a physician in training. I'm a pharmacy student. He said, you just apply. So I went home and I typed up my application and I faxed it in, as one did back then. And I got a phone call and they said, hey, we received your application, but this is a program for medical students. I said, I know, that's what I told them. And they said, well, interdisciplinary care is becoming more important. So we a physician. And if you get it, then we'll tell them and it'll be a surprise. Well, that summer, 14 medical students in training and I went to Washington, D.C. And it was a really big summer in Washington because they had just debated the whole Clinton healthcare system plan, and they handed out a book that explained how all the different parts of Washington work together. And we had meetings with different healthcare stakeholders, including the late John Eisenberg. And if you're a student of health policy or interested in healthcare quality, you know that Dr. Eisenberg kind of created and wrote much of the early work about healthcare quality. But Dr. Eisenberg also left me with an important takeaway that summer. And that was that the different stakeholders in healthcare kind of function like an ecosystem. They all need each other. They all rely on each other. And they kind of work together, but they all value different things. And that if I could learn to speak the different languages that existed in the ecosystem and understand how to exchange the different currency, that I might be able to make a difference in helping the lives of patients. And that's why this chart becomes so incredibly important to me, because even though I don't get to see patients one patient at a time today, the rules that govern the way this system works ultimately has a huge effect on patient health. And I challenge you to believe that understanding how all of these parts of the healthcare system work together and impact the patient on the other side of the pharmacy counter will make you a better pharmacist, a better researcher, or a better teacher. And even now, I try to use the understanding that I've gained over the years to help friends or friends of friends or people on buses or people in lines getting on planes understand how to make sense of the health insurance coverage that they have, and ultimately sometimes pick a plan that best meets their needs. But our system is so challenging that even with my decades of experience, I can't always figure out how to help someone make sure that their health plan will help them get the medicine that they need. Now, I am fairly certain that nobody in this room signed up to go to pharmacy school because they wanted to learn about the healthcare reimbursement that we have in the United States. But understanding it is critically important. We know medicines work better when people use them appropriately and take them on time, right? Adherence is second nature to you. And there's research that now shows that when coupons that are provided by drug companies to help people access their medicines aren't applied by the insurance company to the drug that they're taking, but instead clawed back and applied to their deductible and ultimately show up in the form of a surprise copay, that means people stop taking their medicines. And you know how terrible that can be to their health. Does anyone recognize this slide? Anyone familiar with the acronym DIR? Directed, I should pull up Blake, like, come on up and explain DIR. In all seriousness, there's a challenge in the way that pharmacy reimbursement from pharmacy benefit managers affects the ability of many pharmacists to continue, quite frankly, to keep their doors open. And there is a real movement afoot in Washington right now to make sure that insurance plans and pharmacy benefit managers treat pharmacists the same, and that they don't require these onerous and back-end financially devastating payments. So understanding all of this will help you either become a better advocate for pharmacists, no matter where you go next. Now, I know that Dr. Thompson explained risk adjustment and value-based payment to you. But I think that there's incredible value in understanding this topic at a deeper level, because if you are justifying the value of embedding a pharmacist in a primary care team, or conducting research on the importance of medication adherence, or even an entrepreneur building a new pharmacogenomic service, you have to understand that health plans view patients through a population-based lens. And at the top of that pyramid is the population of patients that represent the smallest number of people, but who actually cost the most per month. And supporting that whole pyramid is the population of people who may be healthy or who may have stable health risk. But in the middle, those second and third bands, those are the people with multiple chronic illnesses. They cost more per month than the health plan is taking in premium. And I ultimately think that that's where pharmacists have the greatest opportunity to demonstrate their value to a health plan. But if you try to divide the cost of your time or the value of your service over 3.1 million members in a health plan, that value is going to be diluted. So understanding how health plans think about risk adjustment or use grouper software to assign different levels of risk to people is ultimately something that I think will help you in any of the settings that we described. And while we're at it, one of the things that Charlie, that retail pharmacist in Palm Bay, helped me understand is something that he called the golden rule. And to him, that meant whoever has the gold makes the rules. And right now, unfortunately, in the United States, the rules of health plans are ultimately what dictate what gets covered. These rules are set by third-party payers. And understanding how those third-party payers think and being able to translate the value of what you do into their language and to translate your value into things that they value, I think ultimately will help support the kinds of care that you want to provide and the types of innovation that you want to bring to pharmacy. Now, the federal government is the largest of these healthcare payers. And that makes the federal government perhaps the most influential part of our healthcare system. So understanding the government's role in setting prices and determining which drugs are fully covered and which drugs are not will make you a better pharmacist, because it will allow you to help patients make the best use of their medicines. It will also help you understand the risks to patients from bad policy. Now, that's where the National Pharmaceutical comes into play. NPC does studies on the value that medicines bring to patients in society and how that can impact our thinking on what policy solutions for patient affordability can look like. And I'm not going to walk through all of these studies, but some recent research that we've done showed that between 1995 and 2015, increased spending on medical interventions ultimately led to improvements in death and disability for 6 of the top 7 causes. And even when you adjust for inflation and disease prevalence, per patient spending actually decreased for 4 of those 7 interventions. Prescription drug spending is, depending on who you ask, anywhere between 10 and 15% of the US healthcare system. And healthcare spending is always going to go up. And understanding how to appropriately deploy those resources, I think, is incredibly important. And one of the things that NPC does is show how we get that bang for the buck on the money that we spend on prescription drugs. Now, speaking of Washington, if you watch the State of the Union, you recently heard that President Biden has called for Medicare to set drug prices, and that there is a movement afoot for the federal government to take a more active role in setting the reimbursement for prescription drugs. The Congressional Budget Office, the official scorekeeper, if you will, of federal healthcare spending, has said that setting prices will lead to fewer drugs coming to market, although it's impossible to predict which ones. Now, we recently published research, and your alum, David Wamba, was a key author of this paper, demonstrating the value of innovation for 8 innovative medicines, drugs that may have never been developed had the incentives for innovation not been presented. And if you weren't sitting so far away from the screen, you would be able to see the increase in life years gained, as well as the financial savings and the lives saved as a result of the development of these medicines. Now, my biggest frustration about the health policy conversation is that something as important as something that's as important as the pharmacist-patient medication relationship can get treated as a bargaining chip for the rest of other government programs. I talked about the Congressional Budget Office. If you spend any time in Washington, you understand that there's an only in Washington government math, a way of balancing the federal checkbook that actually projects future savings by canceling a policy that doesn't get implemented. And one of the policies that was recently implemented would have ensured that the rebates that drug companies provided to insurance companies would actually flow to benefit patients at the pharmacy counter. And when you talk to patients, through the lens of understanding how the supply chain incentives work, you appreciate the fact that what they're paying a co-insurance on is not the cost of the medicine to the health plan. And if that patient is having difficulty affording that medicine, you wish that there was a way for more of that discount to be passed on to them. Unfortunately, what should be a thoughtful, research-driven, evidence-based conversation about these policy trade-offs often becomes reduced to a political talking point or a rhetoric-fueled debate or a horse trading conversation about pay-fors. And sometimes all of the above happen. And I would really like to see more research, more evidence informing better policy, which leads me to the third take. First piece as the head of NPC, I shared my philosophy about this, and we see a variety of incentives like rebates or hard to tackle policy questions like 340B. And now in this new role, I get to work with smart researchers to develop the data to add to this conversation. 340B is perhaps one of the thorniest topics. And just to level set, 340B is essentially a reference to the section of the Public Health Services Act that created a program to allow hospitals and health centers to serve low-income patients by purchasing prescription drugs at the lowest cost, essentially Medicaid prices. The data today is starting to suggest that more and more of these medicines that are being purchased at a discount are being sold to patients that have commercial insurance, maybe not the people that the program was intended to serve. And unfortunately, that's caused a huge argument between stakeholders in the supply chain. And Congress provided very little insight into how this program was actually supposed to work. And some entities are actually keeping the difference between the full price payments and the discounted payments and using that for other purposes. There are some actors in the system who are using these proceeds to do important things to serve low-income communities, but not everybody is. And again, that's just one more reason why I think we need to be able to have a more open and a more transparent conversation to help determine the best solution to help patients and ultimately ensure sustainability. Now, I was going to say in Washington, there was something called diplomacy, and it required grace to work with your colleagues across the aisle to help each other get off of a sticking point or to help them understand trade-offs. And that happens a little less lately. But my strong belief in understanding the importance of what the other party wants and being able to translate what you want into what they want is based on the experiences that I've had in all of these different settings. I understand the importance of medicine because I've seen it turn my parents from cancer patients into cancer survivors. And to me, it's critical that we never trade away today's science and its ability to deliver tomorrow's cures. But as a health plan executive, I also understand the challenge of trying to offer low-cost health insurance or affordable premiums to employers, and at the same time being able to provide access to all of this innovation. Sometimes the incentives in the system don't work the way that they should, and they don't benefit patients. Serving in 2 administrations and spending some time in academia has helped me appreciate the value of evidence and the ability for people who do research to have informed evidence-based conversations with each other. And when I think back on all of these different experiences and reflect on the conversations that I've had here in Oxford over the last 2 days, I believe that that's an approach that can ultimately bring us together and help us get over these sticking points. But all of those experiences are what brought me to this moment today. And I'm just, again, just incredibly grateful to be able to be here with you and to hear you share over the last couple of days what you want to do with your pharmacy degree. Not all of you are going to go into the patient care system, and that's okay. What you're learning now will serve you well, whatever career path you choose. But I'd encourage you to take time to learn about non-traditional topics, to understand the importance of health economics and outcomes research, to understand how policy matters to practice, even if you don't become an expert in policy, and to understand how the supply chain that we described doesn't necessarily work to serve patients. Now, for me personally, I discovered that the best way for me to help patients as a pharmacist is to not work as a pharmacist. We talked at the top of this session about the important role that pharmacists have played in getting America out of this pandemic. And over the last 3 years, we've heard the Assistant Secretary of Health say that they were expanding federal law to allow pharmacists to test patients for COVID. And ultimately, that expansion extended to allowing pharmacists to provide vaccinations. And there are a lot of open questions about, as we move out of the pandemic phase of COVID, are pharmacists going to continue to play an expanded role in our healthcare system? And that's why I get so excited to hear someone like a Secretary of Health and Human Services say that pharmacists play a vital role in delivering convenient access to important public health services, and that they've allowed pharmacists to practice at the top of their license, empowering the public with more options to protect their health and well-being. That's a really cool statement for anybody to make about your profession, let alone the top healthcare official in the United States. Now, as I mentioned in my introduction, that was my boss. And those people were my former colleagues. And I can't take credit for it, right? I left at the end of 2019. And people like Pam Schweitzer, who also graced the stage, have contributed much to the federal government's understanding of the important role of pharmacists. But I'm grateful to have spent that time with him, because just because I left doesn't mean that I don't get phone calls at times for advice. And I'm grateful to have worked with him, by and large every day for the 2 years that I was in, writing policies and speeches and scheduling trips to visit pharmacies and to ultimately launch a number of pharmacist-focused actions, including the DIR proposal that is being revisited by this administration. Now, I dare say that Secretary Azar might have visited more pharmacies than any other cabinet secretary to date, and might have been the only one to ever ask how many student pharmacists were in the room. And when he did that at the NCPA legislative fly-in, he was literally shocked by how many hands went up. And maybe I was the first person to say the phrase top of our license in front of him. But this is what that kind of relationship with a health policy official can do for your profession. And this is possible at the federal healthcare level. This is possible here in Mississippi, working for a state legislator or a senior state healthcare official. And I really want to open your eyes to that kind of career path, or even a short-term experience while you're in school or on your sabbatical as a faculty member. But believe it or not, that wasn't the first Secretary of Health and Human Services that I had met. And I am grateful that just a few months ago, I had the opportunity to teach a class with both of them, and to share a classroom much smaller than this one with two former Secretaries of Health and Human Services was a really cool experience for me. I added this slide at 11 o'clock today, and that was after someone asked me about the importance of relationships. And I wasn't going to mention how important it was to be able to ultimately create and maintain relationships today that will ultimately be able to serve you in the future. And when I think about what I read about Charles Hartman, and how he approached the world and how he refused to wait, it reminded me of a phrase that I'd heard somewhere else about the importance of being brutally opportunistic. And it sounds to me like he was someone who wasn't afraid to take the resources that he had and figure out how to use them to get what he wanted. Pharmacy has so much to give, and it is being recognized more and more each year. And I think we're at a very special point for pharmacy. And I would love to figure out a way to continue to excite, to continue to inspire those of you who may be interested in research, those of you who may be interested in policy, and those of you who may be more interested in healthcare financing. So for those of you who might have felt something about something we talked about today, I am sincerely encouraging you to stay in touch. I have said a number of times over the last couple days that this is my first trip to Oxford, and I hope to not make it my last trip to Oxford. I am more excited to be here right now than I was when I was originally invited to give this lecture, and that's because of the time that I was able to spend with you here today and over the last couple days. There is so much work that can be done to help patients appreciate the value of medicine. And I believe that pharmacy and pharmaceutical manufacturing have an incredibly important shared history, and we need to have a shared future. And that future is going to be one that I believe is value-based. And I believe that the best way for us to get there is to get there together. So with that, I will stop because I'd like to have a little bit of back and forth. I've heard some good questions while I was here, and I wanted to make sure that I left time for that today. So thank you for having me, and I look forward to your questions and/or staying in touch. Can I call on you? Because like you're leaning forward and you seem to like actually connect with some of this. And I just want to know maybe a little bit more about you.
I'm coming with the mic.
I don't know if they bring them to you or you queue up.
Right.
Oh, but there's a Zoom audience, so we have to use the mic.
Yes, sir. Hi, how are you? I had a lot of questions. Yeah, I'll speak loud. You know I will.
Well, there's a Zoom audience, so they have to be able to hear you.
I had a lot of questions about when you were pulling up the actual supply chain diagram. My dad and I have talked about this ever since I was little growing up. He has problems with it. And so I'm really passionate about trying to fix a lot of the problems. What I want to ask about with your MPC company, your infrastructure do you think there's a problem in how you apportion your focus to global problems rather than a geographical centered issue? So the Delta has different problems than Scottsdale, Arizona. So making policies for everybody just reframes the problem we already have.
When you say globally, do you mean like in the United States or?
Sorry, yeah, globalized, like a big picture thing.
Well, that's, you ask a very interesting question, and that's one that kind of gets to the heart of the nature of risk adjustment, right? Because not all patients are the same. And we recently published something that we call the myth of average, and that there are a lot of policy decisions in both the public and private sector that are sort of made at the big picture affect everybody level. But they don't get down and recognize the differences in individual people. And for the majority of my training, the differences in people referred to the genetic differences. And yet we're starting to appreciate even more the importance of things like social determinants of health. Now, there was one class in my P1 or first year of pharmacy school called Social and Behavioral Foundations of Pharmacy Practice. And it was the class that my fraternity brothers called the stuff you don't need to become a pharmacist. And yet, when I fast forward today, right, like that's the stuff that really matters. So when I was going to school at Hopkins, I would drive up through Baltimore and I'd drive by the University of Maryland's Medical Center bus stop. And I'd see people being discharged with their meds and their belongings and like a pillowcase waiting for the bus. So yeah, so paying for care transitions and getting a pharmacist on the readmissions team is incredibly important. But if we don't understand, again, the ecosystem, the environment of where that person is going back to ultimately recover or get well, stay healthy, we're missing an important part of that. And I think you're absolutely right that begins at the community level. Thank you.
I'll also ask a question if I'm not interrupting anyone. What is the best piece of advice you could ask students? I know we have 2 or 3 years left of school, so anything you could offer some wisdom for us.
Yeah, I'd encourage you all to be curious. Don't go to an IPI or an API site or another experience outside of school and just show up and do what's on the syllabus or do what they tell you that you're supposed to do. Much of what I've learned, I have learned from asking people and not being afraid to I admit I had no idea what it was they were talking about. Now, it was funny, I harp on risk adjustment because it's something I wanted to learn like my whole career, because I kept hearing people talk about quality and quality measures and how spending needed to be risk adjusted. And it was like this thing that I could never figure out. And when I got hired by a health plan, the CEO said to me, do you have any questions? And I said, yeah, I am really interested in learning more about like risk adjustment and underwriting and like how you view the world through a premium-driven population-based lens. Will I get to learn that here? And he said, John, you're coming to work for a health plan. If you don't learn it in the first 90 days, I'm going to fire you. And what that gave me the opportunity to do was, again, in the spirit of being opportunistic, to say like, hey, I understand this part of the world, but I need to understand that part of the world. So let me do the bad version of a document. Let me be the first one to try to build this model and see if it turns out the right way. And I've learned a lot by saying I don't know, by trying things and making mistakes, but by also being incredibly curious about what's happening around me. So don't be afraid to ask the dumb questions. In fact, insist on it and say like, hey, I'm giving you the value of my time in exchange for an education. I don't want to just learn about the stuff that you think you're supposed to teach me. I have a lot more questions. And a good leader will say, I don't know the answer to that, but you should spend some time with this person or that person. And ultimately, that's how you begin to build that network. And that's how ultimately I think you're going to find that one person that's going to talk about that thing in pharmacy or that thing in healthcare that really excites you, because we can do so much more with passion. And it is so easy to come into school and follow a syllabus and choose a clerkship site because it's close to where your family lives and you don't want to have to get an apartment or sleep on somebody's couch somewhere else. And the ability to push yourself and get outside yourself while you still have the opportunity to learn, I think is the advice I'd give.
Hi. That's a little bit louder than I thought it was gonna be. So right now our classes are a little bit more centered towards community and clinical setting in pharmacy. But for students who might be interested in more health policy, is there any kind of like extracurriculars or research or internships that you might suggest towards students who might want to go down that path?
You know, believe it or not, when I applied to pharmacy school, you had to check a box telling the admissions department whether you wanted to be a community pharmacist or a retail pharmacist. So you've asked a really important question. I think the answer is yes. There are a lot of internships. There are a lot of fellowships. There are a lot of postgraduate experiences. There are a lot of people who would just like to get together with you every now and then and say, hey, read this and let's talk about it in a few weeks. The challenge is, how do you find it? And one of the things that I'm coming away from my time here with is a belief that there may be no better pharmacy school in the country to build and create sort of, this is the directory, right? Like between three of the people in this room, there is a giant network of pharmacists who have gone to work in non-traditional settings, and compiling their stories into a way that you have the opportunity to hear about those experiences. And if that's of interest, being able to find, okay, where are the opportunities to do that? I believe that building the next generation of health policy researchers and communicators is one of the most important jobs I have. And I'd really like to continue to pull on the thread that was contained in the question you just asked, and see if there's not a resource we can't build together.
All right, we have a question on Zoom. So is there another healthcare model in a different country or region that you believe is superior to the current US model?
No. Look, and I say that in jest, right? That's a complicated question, because how you measure that superiority is a matter of individual and national preference, and that's what frightens me about trying to import what some other countries are doing and thinking it's going to be right for the United States. And that's something that comes up a lot in the drug pricing debate. In 2005 or 6, I was in New Zealand, and all I was reading about in the newspaper was how the pharmaceutical reimbursement scheme in New Zealand had made a decision that a new breast cancer medicine, Herceptin, wasn't cost effective, and that therefore they weren't going to allow access to it in their insurance scheme. And yet over here, many women were already benefiting from that drug. And I wasn't there on a health policy trip. I was there on vacation. And I couldn't stop myself from thinking about how terrible it must have been to appreciate that there was a medicine that could provide value, but because the insurance system in that country had decided that it was above or below an arbitrary cost effectiveness threshold, that women had to wait for that treatment. Now, there were some parts of that healthcare system that I liked, like I could by and large walk off the street into a clinic, no wallet, no insurance coverage, and by and large, someone would see me. When I represented the US to some OECD meetings, I was very excited by the country to my left when they said that they essentially have an electronic health record system that allows them to do like birth to death claims, birth to death tracking of health system utilization, health system spending, et cetera. And I'm thinking like, wow, how awesome must that be for researchers? Now, the OECD it does its business in French. So the United States is États Unis, and the country to my left was Estonia. And I looked up Estonia in my fact book, and I think there were like 1.3 million people. And I'm thinking like, my gosh, like that's Fairfax County. Like that's very easy to have that kind of a system there. So again, I think the decisions that countries make are based on what's right for them, and trying to import those preferences or assume that we can take parts of that system and make it work here is challenging to do.
Thank you so much. I think we're out of time, but thank you, Dr. O'Brien. I do want to thank you for being here today. Thank you for helping us honor the legacy of Dean Hartman. Thank you all for being here today. I hope you all have a great rest of the day. This concludes our program. Thank you.
Thank you very much.